Hello everyone, thank you very much for tuning into our webinar today entitled Dispelling the Myths and Misconceptions around PGT. We're just letting in delegates and we'll start this webinar in 1 minute. If you have questions at any point during the webinar, please enter them into the chat box. We'd love to get your questions. In fact, we've already had quite a few with the registrations, but there's room for more. So please just ask away, pop those questions into the chat box and we will answer these after the presentations. Good afternoon and a warm welcome to today's webinar, Dispelling the Myths and Misconceptions around PGT. I'm Emily Austin, I'm the General Manager of Cooper Surgical Fertility Solutions in the UK, Ireland and Germany, and it gives me great pleasure to welcome you to our webinar today. I've been very much looking forward to this webinar. We've broken our own record with the number of delegates who have signed up. It's great to see so many of you here. Thank you very much for joining us. And we've got a super lineup of speakers for you today. Firstly, joining us today, we're delighted to have our colleague, Amber Gardner, speaking. Amber completed her Master of Science in Medicine in Genetic Counselling at the University of Cape Town, South Africa. Prior to moving to the UK, she worked as both a laboratory genetic counsellor and in private practice in South Africa. Amber's worked in the NHS and with Cooper Genomics since 2017. Amber has extensive clinical genetic counselling experience, primarily in prenatal and cancer genetics. Amber provides genetic counselling for PGT enrolment and results consultations. Amber, we've not had you on a webinar before. Thank you very much. We're looking forward to hearing from you today. And next up, we have a regular contributor to our webinars. I'm very pleased to say that Jen Sloan turns to us this lunchtime. Jen is the lead genetic counsellor for the UK and Ireland. Jen manages the UK and Ireland genetic counselling team and is also an experienced clinical genetic counsellor, having worked in the NHS and Canadian public healthcare system for many years. Jen studied at the University of Manchester and enjoyed living here so much that she stayed. And lovely that you did, Jen. A welcome return to you to our webinar panel. And lastly, joining us today, we have another regular webinar contributor. I'm very pleased to say that Dr. Tony Gordon is with us this lunchtime. Tony is Senior Director of Clinical Strategy and Market Development at Cooper Surgical. He is a molecular geneticist and cytogeneticist with over 20 years industry experience developing new testing technologies, growing businesses and running labs. For the last 15 years, his focus has been in reproductive genetics, mainly pre-implantation genetic testing, where he has led teams that have developed some of the most advanced and widely used PGT tests on the market. Lovely to have you with us, Tony. If you have questions today, please enter them into the chat box. The objective of this webinar is to answer your questions and no question is too small or too big, so ask away. Amber, I will now hand over to you.
Thank you, Emily, for the kind introduction. So the title of this talk is Dispelling the Myths and Misconceptions around PGT, and I'm sure you can all imagine that as genetic counsellors who work in this field, both Jennifer and I encounter many different myths and really some common misconceptions from patients, from our clinic partners, but also from our colleagues who work in clinical genetics. So the purpose of this call is to go through these in a bit more detail and help to maybe answer some of these questions that remain. So just as a starting point, I'm sure many in this audience are familiar with the different types of pre-implantation genetic testing. But just as a quick recap, PGT-A is what we're going to be talking about the most in this call. And as most of you are aware, a screening test for chromosome abnormalities. There are many different technologies that can be used for PGT-A. Currently, we at Cooper Surgical use our PGT-AI technology. And the purpose of PGT-A is to obviously identify chromosome abnormalities in an embryo sample that would then impact on that embryo's ability to result in a successful pregnancy, ultimately to guide transfer decisions. PGT-SR, on the other hand, screens for inherited chromosome rearrangements. So we know that an embryo may be at an increased risk for a chromosome abnormality due to either a parent or a gamete contributor that is a balanced reciprocal or Robertsonian translocation carrier, or carrier chromosome inversion or insertion. And then lastly, PGT-M screens for specific single gene disorders, which may also include inherited microdeletion or duplication syndromes. And this is performed using linkage analysis, either with or without direct mutation analysis where possible. You may still hear PGT-M being referred to as PGD. It's a bit of acronym soup. We hear them still being used both by our colleagues and our patients. So you might again still see, the old terminology in research. So this is just a list of some of the common misconceptions around the different types of PGT. I'll be going through these, and obviously we'll be hoping to dispel some of these misconceptions. I'll be focusing on the first few related to PGT-A, and then Jen's going to jump in to talk more about biopsy and common misconceptions around PGT-M and PGT-SR. So as many of you working in the fertility field will be aware, there's obviously some common indications for why couples or patients might pursue PGT-A. And these might include, unexplained fertility, recurrent IVF failure, recurrent pregnancy loss, or things like advancing maternal age. I would just say to highlight here that, recurrent pregnancy loss, we do know can be caused by either the patient or partner carrying a balanced translocation, for example. And we would really encourage clinicians who are seeing patients with a recurrent pregnancy loss who may be interested in PGT-A to ensure that they have had further investigations to determine whether the patient or partner might have a chromosome abnormality, a translocation that may impact on PGT-A for them, i.e. therefore kind of going down the route of PGT-SR rather than PGT-A. As again, many of us working in this field are aware of the different types of results that you can get with PGT-A. And just to show on this slide, we know that embryos with euploid PGT-A results have the highest chance of resulting in a successful pregnancy, whereas those with aneuploid PGT-A results have a very low chance, with mosaic embryos falling somewhere in between. And we here at Cooper Surgical have these particular reporting parameters where we call a mosaic low level mosaic, if 20 to 40% of the sample is abnormal. And we would call a sample high level mosaic if more than 40 to 80% of the sample is abnormal. Just to note that, again, these are our reporting parameters here at Cooper Surgical, but these may differ from reporting in, say, different studies that you might encounter. For example, in the Biopsy et al. Paper from 2021, they use a 50% cutoff between low-level and high-level mosaic. So just to be mindful of this, if you are reading kind of outcome data from mosaic embryo transfers, that it might not always be, apples to apples, might be apples to oranges at times. So one of the most common misconceptions around PGT-A results is that embryos with euploid results will always produce a healthy live birth. And unfortunately, we know that this is actually not always the case. We know that not every euploid embryo will implant into the womb to form a pregnancy. We know that euploid PGT-A results obviously have the highest chance of resulting in a successful pregnancy, but this is certainly not guaranteed. And that being said, we also know that not every failed implantation or pregnancy loss can be attributed to a genetic or chromosomal cause. And it is important for patients to be aware of, the possible unsuccessful outcomes, even following transfer of an embryo with a euploid PGT-A result. Another common argument is that PGT-A does not improve outcomes, which is why it still has a red traffic light designation on the HFEA website. We will be, thanks Jen, we will discuss in a moment and later in the Q&A some of others' views on this rather controversial topic. But in the meantime, I wanted to just draw your attention to some of the outcome data that has been published. And this in particular, so this is outcomes from the HFEA, or the Human Fertilization and Embryology Authority. And just of interest, if you are looking to see the difference, say, between one clinic and another, the HFEA do publish outcome data on their website and also contrast that with national averages. So from our internal data here at Cooper Surgical, we have found that PGT-A reduces miscarriage rates, and this has certainly been shown in other large studies as well. So you'll see in this graph that across maternal age groups, but obviously particularly in women over the age of 35, the rate of miscarriage is reduced when these patients had PGT-A versus those that did not. And then on the right in the Sanders et al. Paper, you'll see that outcome data from the HFEA suggests that PGT-A may increase live birth rate, particularly per embryo transferred. And this was actually across all age groups. The difference between those that had PGT-A and those that didn't was statistically significant. Another common myth that we encounter is that aneuploidy is only really relevant in women over the age of 35, or that it's so uncommon in women under the age of 35, it's not necessary to include PGT-A, say for couples who are undergoing PGT-M or PGT-SR for other indications, or younger couples who are maybe struggling with fertility and deciding to choose or deciding to have PGT-A as part of their IVF treatment. And this is not necessarily the case. So you'll see here from our global PGT-A data that we see that aneuploidy is, of course, a possibility for any woman at any age. And yes, of course, aneuploidy rates do increase with age, but even for a woman at, say, 25 at the time of her egg retrieval, sporadic aneuploidy is certainly possible, and which obviously in turn could impact on the success of an embryo transfer, resulting in a healthy live birth. The major arguments against the utilization of PGT-A is that of randomized controlled trials. So the argument being that PGT-A has not been shown to be an effective intervention in randomized controlled trials and therefore should not be used in clinical practice. So we do know that there are many of our colleagues who practice by this statement, but I would encourage the audience to really think about this and critically appraise all the available data from other studies before determining that PGT-A is not clinically useful. So there are certainly arguments both for and against the utility of randomized controlled trials. So some of the arguments for doing these trials is that, firstly, they're relatively easy, particularly if you're only using one IVF cycle, which has a short duration. So you're not waiting for patients to come back, maybe over several years, for example, or that patients may drop out of the study, if it's too long. Another argument for randomized control trials is that outcome measures are routinely collected as part of clinical care, which means that these participants would not need to attend, say, multiple additional clinic visits or have any additional testing, because as part of their routine care, these outcomes would be measured. There's also an argument that powerful statistics can be used to account for any potential confounders. So particularly when thinking about multi-center or multi-site trials, that there might be bias that might be introduced or confounding factors. It's argued that powerful statistics can help in those scenarios. And then yes, much of the argument is that, well, randomized control trials work well in other areas of medicine, so why should they not work in the fertility field to assess the efficacy of PGT-A? There are also several arguments against the utility of randomized control trials, and the first is this of biased selection. So I suppose if the idea of a randomized control trial is to remove bias, it is unfortunate that many of the studies that have already been published using a randomized control trial have only really included women who already have a good prognosis for live birth. So for example, those that have at least usually 2 to 5 blastocysts that are actually available for testing. And I would argue, but what about the women with a poor prognosis? So say those who've had multiple or recurrent implantation failures. We would certainly, or I would argue that including these women in studies is extremely important to ensure that any results that come out of these trials are generalizable, across all patients that may seek IVF. particularly those with a poor prognosis who may actually have the most to benefit from PGT-A. And of course, one of the unfortunate downsides to large randomized control studies is that they're expensive and they require significant buy-in from stakeholders and considerable resources, which is why many centers potentially are not interested in running randomized control trials if they can avoid it. And then this last point I think is rather important. What about other large studies that have been published that have outcome data outside of randomized control trials? Can we just disregard this data while we're holding out for randomized control trials? Yes, of course, these might not be trials as we would like to see them, but we can't really disregard the data that's already available about PGT-A. It may not be the data that we want, but it's the data that we have. And really critically reviewing this data and available options, I hope would allow clinicians or providers to decide on what testing that they're going to offer at their clinics to try and practice evidence-based medicine. And then my last couple of slides is just maybe highlighting some of the supporting evidence that some of our colleagues use against the use of PGT-A in their clinics. And unfortunately, many guidelines are out of date or are published in different sources. And I would really encourage colleagues to look at a wide range of different research before making these decisions. As I'm sure you know, obviously you'll find whatever really suits the narrative that you think because of your Google search. And this is certainly possible that you can find information that fits either for or against PGT-A that might fit in with that argument, but might not always be showing you both sides of the story. And certainly we as genetic counselors try to provide patients with an unbiased view of the different types of testing that's available so that they're aware of what current research is showing so that they can make those informed decisions.
That's a great point there, Amber. Can you hear me okay?
Yeah.
Okay, wonderful. So I guess over to me then.
Mm-hmm.
Okay, can you see the next slide for trophectoderm biopsy?
Yes.
Wonderful, thanks. So this is a common question as well. Does the trophectoderm biopsy that's done after IVF to do, genetic testing associated with pregnancy complications? That's a common misconception as well. And this article published in the American Journal of Obstetrics and Gynecology in 2021, so a very new publication or latest. They did look at the embryo biopsies and contrasted that for women who have had genetic testing after their IVF cycle and those have not. And they looked specifically at maternal and neonatal outcomes. So I won't read everything on this slide, but this is just a screenshot of kind of the study design and overall conclusions from the study. They did look at the surveillance data for 3 years from 2014 to 2017, and they considered only singleton births after there was a frozen thawed single embryo transfer. And they compared those outcomes to those who did not have an embryo biopsy after their IVF treatment cycle. So those that did was about 585, and contrasting that to those who did not, over 2,000, close to 2,200. Using their statistical analysis of chi-squared logistical regression and the odds ratio of 95% confidence intervals, they also matched and adjusted for maternal age, race, education, parity, their body mass index, their year of birth, and infertility diagnosis. This is obviously an American study. They also adjusted for insurance as well. Not something we have to worry about in the UK and Canada. The overall conclusions of this study was quite supportive and reassuring for those who are worried about this. Embryo biopsy for PGT does not increase the odds of a diagnosis related to maybe obstetrical complications, for example, preeclampsia, pregnancy-related hypertension, placental disorders, even preterm delivery or low birth weight. They also concluded that maternal conditions such as gestational diabetes, or the maternal or infant length of stay in the hospital after delivery. So very kind of supportive data from that study. This is something I'm sure you've all read in the New York Times last April. This was a flashy title saying that the study raises questions about popular genetic tests for abnormal embryos. So you'll notice that they didn't specify PGT-A. And what is the embryos that they consider abnormal? So we're going to break that down for you, but the overall kind of snapshot that this study wanted to relay was sensationalizing really about 50 patients who underwent transfers for abnormal embryos in New York. And they said there was actually 8 births after 57 cycles of embryos for abnormal genetic test results since 2015. 7 of the babies were born healthy, and the average maternal age was 41. So if we look at that data and break it down, I may have enlarged this graph a wee bit too much. It's a bit blurry. Apologies for that. But the purple bars are, of course, the number of embryos in this study. The red ones are the live births. So you can see that these bars are very low or non-existent in the no result category here. I'm not sure if you can see my cursor. And then the orange bars were kind of the overall percentage. So of course, when you say 1 out of 3 and take that small number to a percentage, it seems quite high, but there was 1 birth from a segmental aneuploidy. A note here at the bottom is that aneuploidy birth also was affected with a heart condition that was undiagnosed. And when we're talking about these abnormal embryos, what are we talking about? A full aneuploidy or mosaic ones? And you can see 6 out of these 7 healthy live births that the study is claiming to have were actually mosaic embryos and not fully aneuploid. You can see here on the right, the fully aneuploid chromosome abnormalities. Out of 106 embryos, only 1 made it to a live birth. I don't have further comments. It might be in the paper whether or not they commented on any diagnosis, genetic or not, and any health implications of that live birth. Moving away more from PGT-A, I just wanted to kind of focus on a couple slides on PGT-M and SR, since we said this was common myths and misconceptions around PGT in general. So here at Cooper Surgical, we complete PGT-M by a SNP-based linkage analysis. So this is not by direct mutation analysis alone, although we're heading towards that. Technically, PGT-M is available for most conditions and genes. We have such a large database of couples that we've serviced for various conditions, and even with the introduction of whole genome sequencing, some very new and rare disorders as well. However, it's important to note that maybe PGT-M is not available for every family. And what do I mean by this? So when clinicians are submitting their molecular reports, what can we do for this couple? Can we help them? Can you assess this for me? So we'll look at the molecular reports, and we're going to assess this on a case-by-case basis. So even though we've offered PGT-M for many couples for cystic fibrosis, that's a very common referral in sickle cell. If they don't have the correct maybe family references, it may not be available for that family. So I'll give a couple examples in just a moment, but really it's important to realize that Cooper Surgical, when we're assessing these molecular reports, it's really not our decision to comment on the severity of disorder or the availability of perhaps medically indicated sex selection. Those kind of queries should actually be going to the HFEA for consideration with our regulations. So if you look here, this is kind of further comments I wanted to make about PGT-M being available for all families. And some of the reasons why it may not be available for a certain family is that they maybe don't have a genetic reference. So someone else in the family that has the condition that may only have a clinical diagnosis and maybe hasn't been tested. If we have the appropriate documentation, we can review that internally to see if that's acceptable. Of course, we have to be careful if it's a more common condition. For example, BRCA1 or 2 related breast ovarian cancers, because we know sadly breast cancer is very common in our population. I already mentioned about the HFEA approval. Usually you can go on the website. We're going to look at this when we're evaluating whether or not we can accept the referral for PGT-M. In the United Kingdom here, we have to have HFEA approval if treatment is happening in the UK and embryo transfer. Genetic heterogeneity is a good example, hypertrophic cardiomyopathy. A lot of the genetic cardiac conditions can have a lot of phenotypic overlap and genetic overlap as well. So one common example is, DMD, that gene is on the X chromosome, most frequent referral for Duchenne muscular dystrophy or Becker. But we also had a referral where the male had that, and he knew that all of his females would be carriers, but of course the males would inherit his Y chromosome. So that's, can also be associated with dilated cardiomyopathy. We're also going to look at the location of that gene. That's why it's really important to have that molecular report, because let's say that gene is located near the centromere, or conversely in the opposite direction near the telomere, we are going to have reduced SNP coverage, pretty much guaranteed, depending on the gene, in one side. So if it's near the centromere on the other side, or if it's near the telomere, an example would be FSHD, we know we're not going to get good SNP coverage because it's really near the end of the chromosome. We're also looking at the type of variation. So we know usually a single base pair, like a SNP, is usually going to be amenable to perhaps a de novo design if there's no family member reference. But we're also kind of cautioning about these large, kind of often deletions and duplications that we see in Duchenne muscular dystrophy, but also PMP22 is another common example. So moving on to SR, again, if you want to learn more about PGT-M, there is a separate webinar that I've done. It's a nice handy reference, particularly if your clinic is just preparing to have their first referral for PGT-M. We really would encourage you to kind of watch that through. There's, lots of answers to commonly asked questions as well. So for SRs, is everybody with a balanced translocation, reciprocal, Robertsonian, inversion, insertion, is that SR appropriate and available for every one of those individuals or couples, whoever is, seeking PGT-SR? We know that about 1% of translocations are sadly unsuitable for PGT-SR. The reason for that is, again, kind of the location of the breakpoints. Usually if they're subtelomeric, we're not going to have that, confidence. Usually if it's over 5 megabases, we will look internally at the breakpoints with the karyotype that you provide to make sure that we can assess it and that we're confident on detecting the unbalanced form. So unfortunately, not all structural rearrangements that are referred for SR would be acceptable. We know some other limitations of NGS technology is that we cannot confirm uniparental disomy. So this would be through NGS technology. The only exception would be really if there was a Robertsonian translocation that involved 14 or 15, we can offer carrier mapping or linkage analysis to confirm biparental inheritance. And then of course, everyone is well aware at this point, hopefully, that NGS, it's going to appear as 46 chromosomes, whether the embryo has the same balanced translocation as either the patient or partner, or truly, whether the embryo has no translocation at all. And this is a nice diagram I kind of include in my letters as well. It's a nice kind of visual representation. We know this is usually tasked with clinical genetics colleagues to explain this when someone has a karyotype done and a translocation has been identified. So we're hoping that referral is still being made to clinical genetics for those couples to really get a good understanding or individual. And this nice diagram I can use during counseling if I'm, sharing screen with a video, and I do include it with my letters. So a common misconception as well is if you're referring for results, particularly PGT-A consultations, is that Cooper surgical genetic counselors will prioritize the results in embryos for transfer, and that's not true, of course. We are tasked with explaining to couples their mosaic results, the potential outcomes, reference what's current in the literature. That Viotti paper is very helpful. This is one of the diagrams from there, kind of explaining the biopsy taken from these 3 different embryos that have the same kind of low-level mosaic result. Potentially, what are the impacts on the inner cell masses, which we're all interested in if and when an embryo is implanted, becomes a pregnancy, what would be the impact, if any, to the fetus? And if the inner cell mass was mosaic, we can expect some impact. If the inner cell mass was euploid, this is where you can have confined placental mosaicism. So just an abnormality in the trophectoderm, but not impacting on the inner cell mass and hence the developing fetus. Or conversely, it could be, representative of fully aneuploid inner cell mass, which would cause great difficulties and likely an early miscarriage if it implanted. And again, this is kind of a nice visual representation of the Viotti paper and outcomes. In counseling, we're really used, Amber and I in person, if we're counseling couples, to share diagrams. This is our specialty in terms of almost like genetic translators, if you will, explaining these complex results, and they can get quite complicated. And fitting that in with the current literature and what's been known, particularly around mosaic embryos, where after we speak with couples, they may be more empowered and feeling perhaps less anxious now that they are more knowledgeable and they know that there are studies out there, and there is a possibility of a healthy ongoing pregnancy and live birth from a mosaic embryo. And usually what we see that, of course, as Amber said earlier, kind of reiterating that point, we would expect that best chance from a euploid. But however, from this paper, it was nice to reveal that it's not a big statistical difference between a low-level mosaic embryo that's segmental versus a high-level segmental embryo. So that's really powerful if you are counseling and the only mosaic result amongst aneuploid results is a high-level segmental. And then, of course, down in order if it's a 1 or 2 chromosome change or complex. So just finishing off here on, this was a new announcement that came through. Our UK London laboratory will actually accredited for MDA amplification. So certain genes we can now offer de novo situations if there's not a family reference, Huntington disease, myotonic dystrophy type 1, and FMR related disorders such as Fragile X. And this is just an example of what that report would look like now with seeing high level, over here, normal versus pre-mutation. Unfortunately, in this example that I grabbed, it didn't have a full mutation. So we are reporting on the actual size of the CTG repeats, for example, Fragile X and FMR1. So thank you very much for your time. Didn't mean to rush through those last few slides, but I really know that there's lots of people that tuned in today and no doubt have lots of questions. We've already had quite a few come through the chat box. So handing back over to you, Tony.
Thanks very much, Jen. And it's great as ever to hear the presentations of the genetic counsellors. You're so good, so clear at presenting the information. And it's a fascinating field with so many questions. So we do have some questions that have come through previously when people logged on to the webinar, and we've had questions that are coming through as we go. So we will try in the next sort of 25 minutes to get through as many of your questions as possible. So I would really say to you, if you have something that has come up in the course of the information presented in the webinar, or if you have any burning questions, providing we can answer them, we will do our best to try and answer them. So without further ado, I will start off with some questions. And this one is to Jen. Is it possible to have healthy embryos via IVF after receiving abnormal results through PGT-A?
Okay, good question. So I think I would first ask you to define abnormal. So kind of punting it back to the slides that I showed about that New York Times article and study that was done. Remember that big, large 106 abnormal embryos with only one, I think they said it was an ongoing pregnancy and live born. So, we know that there are viable pregnancies, viable aneuploidies. So for example, Down syndrome, trisomy 21, Edwards syndrome, trisomy 18, and Patel syndrome, trisomy 13. These are the common viable pregnancies, aneuploidies, if they're, either a natural conception or identified in an embryo if you had PGT-A. Yes, it is possible for those to make it to a live birth, but we know with Down syndrome, Edwards, and Patel, quite severe impacts. Less likely for Down syndrome, of course, mild to moderate intellectual delay. But usually either a trisomy or monosomy, or potentially even some segmentals, usually end in an early miscarriage, sadly.
Yeah, it's interesting how the precision of the language needs to be here, because abnormal could mean a full copy aneuploidy, or it could make a mosaic. And I think you've shown quite nicely in yours and Amber's presentations that mosaics do less than euploids, but they do make healthy live births. And they also very occasionally in the literature do make affected live births, which is really, really quite sad. But it does mean that we can consider mosaics for transfer, or clinicians can and patients can. So fascinating. Next one for Amber. Can we do PGT-M for unknown disorders? Now, we had a little bit of a chat about what actually this question means. So there's kind of a couple of different things it could be. So over to you, Amber.
So yeah, I think there are different ways to answer this question depending on how it was asked in the first instance, but we certainly do get questions about whether it would be possible to do like carrier screening on embryo samples, just like say a couple would undergo say preconception carrier screening prior to starting their families to determine whether they might be carriers of recessive or X-linked conditions. And just to say that, you know, carrier screening in embryos is not something that is available here at Cooper Surgical. Again, it's something that I suppose we'd ask why are you wanting to have that information, and is there kind of other testing that can be done, probably as a starting point in the patient and partner first, prior to considering testing an embryo for something that's already maybe not an established condition that embryo might be at risk for. There's also maybe another side to answer that question, you know, when people are asking about unknown genetic conditions, things like multifactorial conditions, so those that are caused by the contribution of both genetic and environmental factors such as autism or non-syndromic birth defects. You know, these are things that unfortunately we can't test for using any type of pre-implantation genetic testing currently, and these are often given to couples during pre-test counselling as the limitations of both PGT-M and PGT-A and PGT-SR is that we can't test for everything. And so even if transferring a normal embryo, you know, that never guarantees the birth of a perfectly normal child because of all the things that unfortunately are out of the scope of our tests.
Yeah, and great answer, Amber. And I think it just shows you, again, precision of language. Unknown genetics can mean so many things to so many different people. We have a question actually from the audience, and it's about PGT-SR, my favorite subject, as everybody should know by now. So I'll answer this one. So it says PGT by SR for structural rearrangements, for translocations by NGS. If one of the breakpoints is undetectable by NGS and the other segment is detectable, would PGT-SR be offered to the patient using trophectoderm biopsy and NGS? So this happens when you have a carrier of a translocation, and the breakpoints are usually close to the ends of the chromosomes. Right. Our resolution is 5 megabases, and actually the resolution of cytogenetics is higher than that. And quite often we get into a quandary of, could it be seen at the ends of the chromosomes if one of the breakpoints is very close? And it gets more risky if you have both breakpoints towards the ends of the chromosomes. But in general, if we think we can see one from the cytogenetics, we do review this and we do counsel the patients. Sometimes people ask us why PGT-SR costs slightly more than PGT-A, because we review all the cases, we review all the literature, and we do a genetic counselling. But generally, we do accept these cases. So yes, it's very rare for us to turn down a PGT-SR case, except when both of the breakpoints are very close to the ends of the chromosomes. So we have a question, another question from the audience, and I am going to put this one to Jen. So is it ethical that a doctor bothers to herself or himself to explain and advise a patient to go for PGT-A, as the risk of abnormal chromosomes like trisomies is low in women who are less than 40 years of age? The patient is 38 years old. Interesting question there, Jen. I think we might have some views on what the level of aneuploidy might be in a 38-year-old, but over to you.
Right. Yeah. So in general, and Amber kind of outlined this nicely with the chart, both internal Cooper data and what's been published out there as well, stratifying by maternal age. So we know that above 35, that's when we see a greater chance or risk, depending on how you look at it, of having an aneuploidy present if you do PGT-A testing. It doesn't, and Amber touched on this earlier too, it doesn't mean that it can't happen to someone who's younger as well. I remember a point where, you know, most babies with Down syndrome are born to younger mums, and potentially that's because maybe they're not screened for, during the pregnancy as rigorous or what would be offered to a woman who's over 35. In terms of kind of the ethical dilemma for offering PGT-A, is that the correct question? If it's less than 40, yes, go ahead. I mean, I'm not trying to sell you PGT-A, but I think the data shows clearly that there is a benefit. And then we kind of outlined that already.
Yeah, it's an interesting one, isn't it? Because obviously it's a selection tool, and if there's no aneuploidy, it doesn't really work so well. That's why I think the randomized control trials for this sort of very much for the under 30s don't really show much benefit. But yeah, there we are. Okay, and then we have another one. What are the risks of no result and damage to the embryos from biopsy and freeze thaw process? I think we kind of addressed the biopsy question in the lecture. The freeze thaw process again is something that we're the genetics lab, not the IVF lab, so it clearly has to be done well, and it's not something that as the genetics lab we can assist. Cooper Surgical fortunately has a large number of very experienced embryologists and products for freeze thaw, and I'm sure it can help. So yes, the biopsy has to be done well, and the freeze thaw process, because if you don't get an embryo come back, it doesn't matter what the genetics are if it doesn't survive that process. What we do though have is some data that we're just collating for publication, and it is from first biopsy and rebiopsy. And the evidence suggests that rebiopsy is as successful generally as first biopsy in our hands. So we get about 2 to 3% of samples fail, and if you do a rebiopsy, you only get 2 to 3% of those rebiopsies fail. So it's a pretty good area, and if you get something that is failed from first biopsy, the rebiopsy is usually the same kind of expected aneuploidy from maternal age as we normally see. I mean, in your experience, Jen or Amber, either one of you, what do you say to patients about failed results and rebiopsy?
Yeah, I get that question quite often, actually. If I mention it as a limitation potentially at time of enrollment counseling, then couples or individuals want a number attached to that. So obviously I'm going to defer that to their providing or referring clinic for kind of clinic specific data. But for a risk of a rebiopsy, I couldn't really quantify. I'm glad that we're doing kind of internal studies, but reassuring them that usually a no result is, no intact DNA or insufficient quality. So, rebiopsy is an option. Speak to your ordering clinician about that. But it is encouraging, like you say, that usually we do get a result from a rebiopsy.
Yeah, I think it's important, and it depends on platform as well. We get a very low, and I know some other platforms have had problems with things like chaotic embryos coming back as euploids, so it's good to see that. So we've got one question that's just come up, and a question that was posed when people logged on, and it's one of those questions that could be a webinar on its own. So it's going to be interesting to see how we get through this as a response. Embryo self-correction literature, how to reassure patients about this matter. Jen.
Okay, thanks. Yes, I mean, I do hear that. I do presentations at clinics with our account manager as well. That's often a question that comes up. Why even bother doing PGT-A if we know that embryos can self-correct? Let's kind of dissect that for a bit. Maybe potentially it could be an aneuploidy or mosaic finding that it's only confined to the placenta, and actually, as I looked at those diagrams earlier, not maybe impacting the inner cell mass at all, and hence not impacting the growing, developing fetus should that embryo be implanted. We know that our DNA is quite sophisticated. We have kind of internal spell checkers, if you will. We can recognize, our DNA I'm speaking of, can recognize if there is an aneuploid cell line. And yes, maybe that's one mechanism we have to kind of stop kind of induced kind of internal cell death or apoptosis to prevent that cell line from growing and developing and turning into something more detrimental potentially for that embryo or implanted embryo. In terms of the literature, I think, Tony, you had a reference that you wanted to talk about maybe for that.
Yeah, I mean, it's interesting because a lot of people have looked in a great deal about aneuploidy and how aneuploidy progresses. Right from the very early days of us doing the first polar body array CGH for PGT-A back in the day, you get almost all aneuploidies in a polar body. And then as you progress through for day 3, day 5, day 6, you get fewer aneuploidies, and some begin to become more predominant, like trisomy 16, trisomy 22. And that is the way things look as you go to prenatal testing, where obviously you don't see some aneuploidies at all. Now, the question is that a kind of pre-programmed apoptotic removal of the cells, or is it just kind of Darwinian selection that those cells die out? There is some literature where people have looked at blastocele fluid. That's the sort of fluid mass in the inner part of a blastocyst, and looked to see the DNA there, and seen a little bit more aneuploidy than when they compare it with trophectoderm biopsies. And the idea is possibly that those aneuploid cells are recruited into the blastocele. Again, people have done some of these studies looking at cells that are discarded from the embryos, and there's a really nice paper recently by Darren Griffin and Bill Kearns that shows that some of those cells excluded into the sample media as intact cells have more aneuploidy than the embryo. But I think, Jen, you hit on something very true. It's not like embryos completely can edit themselves and remove all aneuploidy. We still see a large amount of aneuploidy, and miscarriage via aneuploidy is one of the main sources of pregnancy loss. So it's not something that you can ignore. And with advanced maternal age, the situation is clearly, it's a real predominating factor for pregnancy loss and IVF. So it's an interesting subject all on its own. So we have some other questions here, and we have some more questions that are coming through as we talk. So good to see that. So one for Amber, non-selection studies. These are an interesting innovation in the field, and I'll come back to talk about randomized controlled trials because I've been involved with a lot of them. Is it important to run a non-selection study, and how challenging are those ethically to run?
Yeah, that's a really good question, and I suppose it's different. I mean, for people who work in this field and are dealing with couples who are struggling with infertility, who have maybe lost multiple pregnancies before they've come to talk to us, the human factor is maybe what affects me when I'm thinking about whether a study might be ethical to run. And you have to, suppose, think about how multiple miscarriages can have an extremely detrimental effect on a couple who have maybe already struggled with infertility for a long time. If you're not using selection to, select for embryos that have the highest chance of resulting in a successful pregnancy. That being said, there's also been shown that using PGT-A can reduce the time to get pregnant. And I think that's also quite an important thing to just bear in mind, particularly for, couples that are maybe undergoing IVF funded through the NHS with others kind of PGT, particularly PGT-M or PGT-SR, not allowing patients maybe to endure, several failed implantations before they can actually fall pregnant just by randomly selecting embryos. And in that case, there would be an argument for the use of PGT-A to help select embryos prior to transfer that we know have increased likelihood of resulting in a successful pregnancy and a healthy live birth.
Cool.
I hope that helps to answer the question.
Yeah, no, you're absolutely right. And it is always very difficult to run any form of trial because, as you say, it's that you've done a biopsy, and at some point somebody is going to get an aneuploid transfer, and how to deal with that. And there are ways you can do that in protocols that you can unblind at certain stages, but it is always a challenge to know that you're not going to give patients that information in a blinded study. I think we all struggle with that.
Yeah, I suppose also there's a difference between, giving a patient a placebo, in a drug study where a placebo isn't going to have an effect,
Right.
versus giving knowingly transferring an aneuploid embryo, which we know has a detrimental effect. There's plenty of research that has shown that. So yeah, I mean, I think that ethical question is one that probably sits with a lot of different people, and maybe more so those who are speaking with couples who have gone through maybe a horrific roller coaster ride to get to the point that they are. And I don't think they would maybe want to sign up particularly for a study where, there is a chance that aneuploid embryos may be transferred.
Yeah, no, absolutely. So we have a question from the audience. I'll answer this and then I'll come back to Jen for another question. So it says, how far are we away from reliable non-invasive PGT-A? So non-invasive PGT-A involves us taking a part of the media that the embryo grows in rather than the biopsy. And what we know is that as embryos grow and expand, some of the cells are discarded, or some of the DNA is discarded into the sample media, and you can analyze that sample media rather than taking a biopsy, which, although we've seen from some of the evidence presented here, we don't think that biopsies are detrimental. It still would be an ideal world where you don't have to touch the embryo at all. So we could just go for this sample media. It's great in theory. There are a whole bunch of issues with non-invasive PGT-A in that you have to change the embryology process. So you have to make sure that the cumulus cells around the egg, those cells that surround, are completely removed. So you get none of the maternal DNA still in the media when you take that sample at day 5 or day 6. And the reason is you only get a tiny fraction of the DNA sample in that sample media. We think probably less than a cell equivalent or a cell equivalent, and it's in a kind of unsuitable media for our technology, our amplification technology. So it's not very robust from that point of view, and it can be confounded by this sample media coming in from the DNA coming in from the sample media from these maternal cells. So there's kind of issues there. It's one of the reasons why a lots of the people that have started offering this don't offer gender, because it's not reliable.
Right.
If you are able to offer gender in certain countries. And also the embryologists have to change process, they have to do media swaps, they have to grow in small medias. So I think, it is going to be the future at some point when we've ironed out all the problems. But at Cooper Surgical, we don't offer it because we see as many disadvantages as potential advantages. So it's an issue that's not going to go away, but it's something that we're looking at still. So one for Jen, and I think from my point of view as a cytogeneticist, one of them really interesting questions. Again, it comes down to, it's funny, this Q&A is coming down to language and precision of language. It comes down to precision of language. Why is it important to be able to detect segmentals? And I would add to the questioner's details and saying, why is it important to be able to detect full copy segmentals and mosaic segmentals and differentiate between the two? Yeah, exactly. Go for it, Jen.
So if we are to first address, mosaic segmentals, well, we know from the Viotti paper, and I shown on my slides earlier, there's not a significant difference between low-level segmental mosaic embryos versus high-level segmental embryos. They don't have a significant difference in terms of implantation, perhaps ongoing pregnancy and live-born. And it's almost the double-edged sword that we really want to make that distinction between mosaic segmentals versus fully segmental aneuploid embryos. And those we really want to identify because they are more likely to implant than a full chromosome aneuploidy, or maybe 2 chromosome aneuploidy, a more complex one, and potentially form an ongoing pregnancy. And if it made it to a live birth, we don't know in that segment that is deleted or duplicated, how many genes are in that segment? How large is that? How small is it? Where, what chromosome is it on? Do we know the function of that gene or the genes in that deletion or duplication? It is likely going to have an impact on growth and development if it's a fully aneuploid segmental embryo that's implanted. And that's, they're going to be larger than these smaller kind of what we call microdeletions or microduplications that can even have an impact. So if we're talking about a larger segment deleted or duplicated in every cell that we see, that's usually an embryo that we would want to avoid. But a green light maybe towards, with the literature to date, of the mosaic kind of low level and high level ones.
Yeah, thanks, Jen. Again, it's a fascinating area because it's the best and worst of cases. Full copy you really want to avoid because the outcomes can be very, very
severe,
negative, severe.
Yeah.
Exactly. Whereas segmental mosaics, especially low levels, seem to do not far off as well as euploids, and they're the ones, if you don't have a euploid you want to transfer. Absolutely, I can see that. So we do have a question that I'm going to take here, and we are running up to the end of the hour. I think this might be our last one, unless we get any questions from the audience, but I'll give this one a shot, because it's one of those ones that always comes up in a UK webinar. Why does the HFEA have a red traffic light for PGT-A? So the traffic light system is a very well organized, efficiently run, defined system for saying whether an add-on should be recommended or not. If you go into it, it has some interesting details. So a traffic light can only be green or amber if it is for the majority of patients. That's the first thing. Now, the literature is fairly small when you get down to the randomized control trials that they consider, because they are only considering double-blinded, multi-center randomized control trials, and in their analysis, some of them were excluded because they considered they might have bias or they're single center. So of the kind of 10 randomized control trials, you end up with only a couple. There's only 2 randomized control trials for PGT-A that use the technology that we use these days, which is next generation sequencing, and also look at blastocysts, the day 5, day 6, day 7 embryos. And one of them is a Chinese paper that came out in New England Journal of Medicine last year, Yan et al., and the average age of patients there was, I think, under 30. And they saw no improvements of live birth rate, which is possibly what you might expect because there was very little aneuploidy. So clearly the traffic light system is not going to reflect that it benefits all patients. Now, I've been part of a randomized controlled trial where we looked at under 35s and over 35s, the STAR trial, and that trial was overall showed no benefit to patients. When you split up the data from the STAR trial, over 35s, we saw a 14% increase in live birth rate. But because that was what they call an ad hoc or a subsequent analysis, that's not considered by the HFEA in their strict criteria. So the one trial that looks at the age group that we give people PGT-A is kind of not really considered by the HFEA. And I know that they're looking again at their traffic light system because it is very, very constrained, and it uses cumulative live birth as well, which is an interesting measure. I think the thing that I would maybe have a little bit of disagreement with the HFEA about their system is they say there's no evidence for other benefits, whereas I think there's pretty good evidence for things like reduction in miscarriage from PGT-A, maybe time to live birth. So it's an interesting place where the traffic light is in the HFEA, but I appreciate you have to put a system in and you have to stick by that system, and that's fair enough. So I think that's pretty much where we are now, coming up to the hour. So back over to you, Emily. Oh, and thanks, Jen and Amber. Great conversation as always.
Thanks, Tony.
Yeah, thank you very much indeed to our panel of Amber, Jen and Tony for dispelling the myths and misconceptions around PGT this afternoon. It's been a really stimulating discussion. I've enjoyed listening to that. Also, thank you very much to Tenna, who you can't see, but she's there in the background. She's organised us all and promoted and run the webinar today. If there are any other genomics or lab or theatre procedures or aspects of fertility that you'd like us to cover in a webinar, please do let us know. We do welcome your requests. Our next webinar will be on the topic of cryopreservation billing and our new service Embryo Options, which is an automated service that we provide to optimise the entire cryobilling process, giving you improved collection rates from patients and reducing the workload and pain for the lab, and also improves engagement with patients. So keep an eye out for that. If you'd like to be kept up to date with the Embryo Options webinar and our other webinars and in-person events, then you can do so by signing up to our fortnightly news bulletin. To be registered to receive this, just send an email to our customer services team, that's customerserviceuk@coopersurgical.com, or ask your account manager to sign you up. So it just remains for me to say thank you very much for joining us today. It's been a pleasure to have your company. Thank you for your many and varied questions, and we shall look forward to seeing you again either in a webinar or at an in-person event soon. Thank you.